Hello and welcome to another edition of Cerhi Half Hour from the Center of Excellence in Reproductive Health Innovation, University of Benin. The program is brought to you in collaboration with the Nigerian Television Authority. In this episode, we shall be looking at another major health issue that affects women, ectopic pregnancy, otherwise called extrauterine pregnancy. We're happy to have in the studios an expert gynecologist and obstetrician par excellence. He's also the center leader of Cerhi, Professor Friday Okonofwa. Prof, welcome to NTA Studios.
Thank you very much. Thank you for inviting me.
We also welcome Dr. Wilson Imogan, a medical expert. He's here in the studios as we steer the program together. Dr. Imogan, welcome, sir.
Thank you very much.
Former Commissioner.
Prof, yes, Prof, I heard you. Well, let's start with the issue at hand. What does ectopic pregnancy mean?
Ectopic pregnancy simply means pregnancy that takes place outside the womb. The womb is the uterus. That is the normal site for a normal pregnancy. So if pregnancy takes place outside the womb, which is the uterus, it is called an ectopic pregnancy. The commonest site is the fallopian tube, which is the tube that connects the ovary to the uterus. I will explain that later on. Then it can also occur in the ovary itself. It can occur in the abdominal cavity, where the abdomen is with the intestines. The pregnancy can occur there. And it can occur in the cervix. Those are the most common sites of an ectopic pregnancy. Pregnancy that occurs outside the uterus, outside the womb.
Okay, Prof. The uterus, the womb, those are internal organs. Am I right?
Yes.
So how does it present that the woman now knows, or somebody now knows that there's something, or is it wrong for that to happen when pregnancy occurs outside the womb? Let me ask that first.
Yes.
If it's wrong, then how does one know that something like that is happening?
Yes, the first thing is that why it is wrong is because the womb is the place that nature has prepared to take a pregnancy. It's specially prepared in the sense that the muzzle there is thick. And so when the pregnancy is expanding, you see the woman's abdomen getting bigger and bigger because the muzzle of the womb is able to stretch and to accommodate the pregnancy. By contrast, any other position, though it's not prepared, fallopian tube, for example, has a very thin lining of muscle. So after some time, maybe after 8 weeks of development, it can rupture and burst. And then the woman begin to bleed inside the abdomen and can come in shock. And that's how they normally present. It will rupture ectopic pregnancy because the fallopian tube is not strong enough. The muscles there are not strong enough to take it up to term, like we see if the pregnancy occurs in the womb. And so it ruptures, and then the woman will feel dizzy, she will feel faint because she has lost blood in the abdomen, and so on and so forth. And until that is stopped and the pregnancy is evacuated, it will be a very major problem for the woman.
Okay, Prof. Sorry, Dr. Logan. Let me just, because it's frightening, well, to me, the way Prof explained it now. What it means is that before the fallopian tube ruptures and the fetus is developing outside the womb, the woman does not know.
Yes.
Especially a woman who does not go to hospital or who...
Yes. There are some telltale signs. Like, for example, a woman, the way ectopic pregnancy occurs is that normally when there is sexual intercourse, spermatozoa are released and they pass through the womb into this fallopian tube. At the same time, the egg that the woman releases is released from the ovaries, and then they meet at the fallopian tube junction. And then they fertilize, and they become a baby. From that point on, it is supposed that that fertilized baby will now move from the fallopian tube and come into the uterus itself and be transported to the uterus where it is now embedded and the pregnancy continues to grow. Now, if there's an impediment to the movement of that fertilized egg from the fallopian tube, and that impediment can be due to the fact that the road is rough, maybe previous infection, the fallopian tube has become rugged, has become convoluted. To that extent, it's not able to move the fertilized egg into the uterus. It gets entrapped there and therefore begins to develop and become bigger. And usually, women who are observant, when the pregnancy is getting bigger outside the womb, when they are very observant, they will notice that they will have mild abdominal pain, which at that time it has not ruptured. Sometimes they will feel faint, and so on and so forth. Sometimes they will feel that because the pregnancy is outside the womb, they may not feel the usual signs of pregnancy, the big way they normally feel it, and so on and so forth. So that a pregnant woman who's observant will know that throughout pregnancy, in a normal pregnancy, from beginning to the end, a woman is not supposed to have abdominal pain, especially if the pain is on the left or right side of the lower abdomen. If you are going to have a pain and it's coming from the uterus where the baby is implanted, it's supposed to be at the center of the lower part of the abdomen. But if you have pain occurring on either side on the lower abdomen and the woman is feeling faint and dizzy, then that's a telltale sign. And then if he misses her period, of course, and he's having those signs, then she immediately do some tests to find out whether it's a pregnancy occurring within the uterus or outside the uterus.
So, sir, why will a particular woman have the baby in the fallopian tube or outside the womb? Maybe sometimes even in the abdomen, and other women do not have. What are the risk factors?
Very good. The most important risk factor, and I'm not going to dwell on too many things, because if you ask that question to a medical student or a doctor, he will give you so many risk factors. But for the purpose of this, the commonest risk factor is a previous infection that damaged the fallopian tube. And that infection are three types. One could be sexually transmitted infection from gonorrhea, chlamydia, damaging the fallopian tube to the extent that instead of having a smooth cilia lining the inside of the fallopian tube, it enables the fertilized egg to move from the fallopian tube into the womb. The tube becomes defoliated, it becomes rugged, and therefore it's not able to move. And that movement is delayed, and therefore that's what causes the entrapment. So infection, and there are two types of infection. One is sexually transmitted infection, either by gonorrhea or chlamydia, which is another more silent infection we often forget in this country. The second infection is post-abortal infection. A woman has had abortion, she has infection from it, and without knowing, the tubes will be damaged. And the third type of infection is after a woman has delivered, and she has had a normal delivery, and there's infection during the process of normal delivery, and the fallopian tubes, and the endometritis leading to what we call saprophygitis, which is inflammation of the tube. Those are the three commonest. And you know, when we say that Nigeria or Africa, there is increasing rate of ectopic pregnancy. Since I was a medical student to date, the rate of pregnancy outside the womb has increased almost by 30%. And at the University of Benin Teaching Hospital, where I work, almost on a weekly basis, we see 1 or 2 cases of ectopic pregnancy recently, which is due to the fact that the rate of these infections that I talked about, sexually transmitted infections, post-abortal infections, and post-delivery infections are increasing everywhere in this country. And also in other parts of Africa, indeed.
You say the problem is increasing in number. What is the disease burden and prevalence of ectopic pregnancy in Nigeria?
Well, I just cannot mention figures. When you say disease prevalence, I would say for every woman that gets pregnant, for every 100 women that get pregnant, about 2 will have an ectopic pregnancy in this country, which is quite high. You know, ectopic pregnancy meaning pregnancy occurring outside the womb.
Okay, Prof. Is it preventable?
Yes, it is preventable to some extent, because there are some other causes of ectopic pregnancy which might be difficult to prevent. But let me also give you 2 instances. Yes, sexually transmitted diseases that I mentioned can be prevented. So ectopic pregnancy due to infection of the tube can be prevented, either by the fact that you are you are not doing multiple sexual partners, or you are using condoms to prevent sexually transmitted infection, or you are managing abortion in a safe way such that you don't have infection, or that when you are pregnant and you are about to deliver, you deliver under safe circumstances, infection not completely cleared, and making sure that a woman who is pregnant does not experience infection. So that's one. But increasingly, we now have what we call IVF, in vitro fertilization. And there are a number of ectopic pregnancies resulting as a result of increased use of IVF. That cannot be completely prevented because women who need IVF are a special group of women that require that procedure. And then basically, thirdly, we just generally addressing that. Those are the things that can be prevented in terms of the prevention aspect of ectopic pregnancy.
Outside the pain that is usually associated with ectopic pregnancy, is there also bleeding?
Yes. The first thing to say when you want to know in early part of pregnancy, which is about the first 10 weeks of pregnancy, that's when ectopic pregnancy tends to occur. You're not supposed to have pain. Pain, if you're having pain when you are pregnant, then ask yourself, where is the pain? Is it lower abdomen? Is it in the central part? Then if that is so, normally, first of all, if it's abortion, there is what we call spontaneous abortion, miscarriage. Miscarriage, bleeding will start before pain sets on. So if bleeding starts before pain and it's in the central part of the abdomen, it's likely to be a miscarriage. But if pain starts before bleeding, usually even the bleeding we are talking about tends to be internal bleeding rather than external bleeding. So if you begin to have pain and later on you start seeing brownish discharge of blood, then it's likely to be a ectopic pregnancy. And then the bleeding we are talking about is internal bleeding. The person will be bleeding inside the abdomen because it is a ectopic pregnancy, the fallopian tube that has ruptured. And unless you quickly go and operate to stop that bleeding internally, then before you know it, the woman will have lost too much blood.
Okay, Prof, let me ask this. At the point at which the fallopian tube ruptures and even all these incidents of ectopic pregnancy, is there a situation where perhaps there's surgery or whatever, that pregnancy is retained or there's automatic miscarriage?
Because the pregnancy can never be that big outside the womb for it to be retained.
Okay.
Usually, most ectopic pregnant, looking at the fallopian tube, by the time the pregnancy is 10 weeks, that's the biggest I've seen. Maybe if it occurs around the conum, which is the corner of the womb, it serves as an ectopic pregnancy. The muzzle there is a bit thicker. It can last to about 11 to 12 weeks. At that point in time, it will rupture. But from the fallopian tube, beginning from that tuber end to the end of it, the maximum you can get is about 8 or 9 weeks. And the bigger, the longer the duration of the menorrhea, the pregnancy, the more severe the bleeding becomes. So if the woman ruptures at 9 weeks of pregnancy, then it means that the pregnancy occurred towards the periphery of the fallopian tube. And if it ruptures at that time, the blood vessels will have become very big and the bleeding is likely to be more severe.
So in effect,
but there are some instances, there's a very classic case of abdominal pregnancy and it has been reported in the literature in the sense that sometimes the rupture will occur at about 6 to 8 weeks. It will drop into the abdomen, to the peritoneum. The fallopian tube will rupture, will burst. The sac of the pregnancy will burst with the baby still alive and then enter the bigger abdomen. And because the bigger abdomen has a bigger space, the pregnancy continues. And eventually, before you know it, it will develop blood vessels and become a normal baby. And we have had instances where normal babies are delivered out in the abdomen, involving the intestine. The intestine will get involved, the colon will get involved, and so on and so forth.
So how long can a woman can carry that till term?
Till near term, yes. We deliver babies like that near term. And then what we do is we just deliver the baby by cesarean section and leave the placenta there. The placenta eventually dissolve itself without any problem. And with something
you don't remove the placenta.
If you remove the placenta, the woman will bleed to death. It's not going to be easy because the placenta has now embedded itself to the intestines, to the colon, to the bladder, and if you try to remove it, you are in trouble. There's no way you can put a suture. So you just leave it there and give it some drug for the placenta to eventually dissolve. That's what we call advanced abdominal pregnancy. Advanced abdominal pregnancy. Pregnancy occurs in the abdomen and is advanced and baby is delivered. Sometimes baby is alive, sometimes baby is not alive. But most of the time baby is born alive.
It used to be thought that that was a myth, that people
exactly,
carry pregnancy outside the reproductive system.
I didn't know that it was why I meet because
No,
for
people
several
say it
generations,
was, a lot of
right from the
people
time I
thought
became a
that
medical student, that phenomenon has been described, that pregnancy can start after that.
outside the
Sorry, Prof, let me
country.
still, I'm still not clear about this. Well, maybe not myth, but there have been stories that once a baby comes out and the placenta does not come out, then that is a problem. Even, well, as myth or even traditional belief, it's as if maybe it's been caused by, well, one,
Something.
exactly. So I don't understand it, Prof, that the baby comes and then placenta is retained and then there's no problem.
In the abdomen, but you see, if it was an intrauterine pregnancy occurring in the womb,
Okay.
the placenta should come out. If it doesn't come out, there are ways in which you can remove the pregnancy. That's the one you're talking about.
Okay, sir.
When the baby comes out within the womb, placenta ought to come out. Although sometimes the placenta become adherent to the womb in such a way that it's almost bound, very difficult to remove the placenta. But in 95% or 98% of cases, once the baby is delivered, we just cut the placenta and we give a drug and the placenta is also delivered. And that is within the uterus. But if the baby is advanced and the pregnancy is occurring outside the uterus, it's very dangerous to attempt to remove the placenta. There are drugs we can give for that placenta to undergo what is called autolysis, self-destruction, without destroying the intestine. If you try to remove it, it will be difficult.
Ectopic pregnancy, sir, is an obstetric emergency. And our health system is very weak. Even in the big cities like Benin, it's still very weak. Access is poor. Now, what are the health system infrastructure that is there to support ectopic pregnancy management?
Well, the health system, from what I know, the major challenge is the woman herself recognizing that she has an ectopic pregnancy. You know, the health-seeking behavior, a woman is pregnant, most of the time they don't even report that they are pregnant. They will stay at home. Sometimes they might even not believe that they are pregnant. There are some women who are almost 10 weeks or 20 weeks pregnant, they don't even know they are pregnant. And when they now begin to experience symptoms, they stay at home. You know, the women that have problem with ectopic pregnancy are women that have pain of ectopic pregnancy, have symptoms, and even collapse. Some people collapse in the market. In fact, cases of ectopic pregnancy, they are in the market, they collapse, they are rushed from the hospital, from the market to the hospital because of an emergency. And I can tell you, sitting where I am now, that the University of Benin Teaching Hospital, where I work, has improved considerably in responding to such emergencies. And ectopic pregnancy is one of the things that gynecologists is what I call something very easy to identify. When you are a medical student and you are taught ectopic pregnancy, the first case that comes, you will see it, you will make the diagnosis. It's not difficult. And that is one of the emergencies, as we said. And for teaching hospitals, it's something that you should not take to a health center, by the way. It's a hospital, teaching hospital, special hospital condition, because you have to operate. And there are various ways of doing it. And, you know, and once you get there, facilities are there to manage the case.
That exactly is my question. In the city, we have UDTH,
Yes.
and perhaps in other big hospitals. What happens if a lady in Ewu
Yes.
or in Uzeba?
Why Ewu? Dr. Morgan, why Ewu?
It's
Because
one of the,
Why don't you say
Ewu is the
Gobazuwa?
I said Uzeba. Why not Uzeba?
Oh my God.
So rural area.
No, but Dr. Morgan, you are once the Commissioner of Health in Edo State,
Okay.
so you are the one better able to answer that question. Because
No,
if
you are educating us. That was 15 years ago, sir.
no, but
Now.
you are still you are a member of the PDP.
Was it there
Very
15
well.
years ago? Was there access 15 years ago?
Perhaps, because as good.
No, in joke, I think that was a joke. The truth is that what he's saying is correct. That is, the healthcare system should be so formulated such that everybody has equal access to such emergencies, universal health coverage.
Yes, sir.
So this is why we still have to get such a woman to the health center. Every single ward in this state and in this country is supposed to have a health center. And so when such a woman reports in the health center, there should be a mechanism to refer that woman from a health center, because operations cannot be done at the health center level. But nurses who are there should be able to identify an ectopic pregnancy and quickly refer to a higher level healthcare facility. For example, we mentioned AWU. If a woman has such a problem in AWU, my health center in AWU, it should be immediately transported to Iwa Specialist Hospital, which is about 5 kilometers away on a very good road, and so on and so forth. And what then happens is that communities should come together to find a way of transporting such a woman. Because I know the ambulances that governments are supposed to provide are not available generally. The good old days, we used to hear ambulances, and we used to hear sirens, and the only sirens we had on the road were the one bringing people are sick. But these days, the sirens are for politicians.
The politicians are taking over sirens.
And so, which is the problem that we're facing.
Let me, Prof, you have perhaps tried to explain this health system issue.
Yes.
I want you to look at the model that was in Ondo State, Abiye model.
Yes.
How can we think of such a facility across the country?
No, but actually, Abiye is what my friend Dr. Mimiko did differently, was to give a telephone to every pregnant woman. And every woman who's pregnant must have a telephone. And in the project which we did here in Edo State, Ectopic, and you were one of the people that did the project, we were able to give a telephone to women, and whenever they experience an emergency, they will test a code to a server. And that server will immediately also test another code to a transporter. And one of the transporters are normal taxis in the village who have been registered, pre-registered. So, and that code will be go to the, for example, go to the transport owner, and the transport owner will be told the location of the woman, where the woman is experiencing complication. And she will go right to that place, whether in the morning, afternoon, or evening, or night. And immediately transport the woman to the health facility. Meanwhile, the same server would have sent that same information to the primary health center, telling the primary care worker that somebody is coming with a complication.
Okay.
And that is still ongoing now in 2 communities, Ectopic in Edo North and Ewatu in Edo Central. So those are things we can find so many innovations of that nature to use.
2 questions before, but we're already being rounded off. Can a woman get pregnant again after the fallopian tube ruptured?
Yes, she can get pregnant again, because we are talking about 2 fallopian tubes. If one experiences an ectopic pregnancy, we tend to remove that. Most of the time when we manage the ectopic pregnancy, we tend to tie it up. But usually the other one, if it is normal, the woman can still get pregnant with the second ectopic. But we also know that most times the 2 tubes are damaged to some extent, partial damage. So if one has an ectopic pregnancy, the other one is left behind, it's possible that yes, the woman can have another normal pregnancy, but most of the time, a woman who has had an ectopic pregnancy is more likely to have a repeated ectopic pregnancy, because most of the time, the other tube is also more likely to be damaged.
Is it
so
treatable?
You should watch out.
Okay. Is ectopic pregnancy treatable? I'm asking as a lay
person.
No,
it's very treatable. Yes, it's treatable provided the woman gets to hospital in time before she bleeds very severely. She's treatable with something you can treat. And like I said, there are many ways. If the tube is not ruptured, we can even put a small scope in the abdomen and just suck out the womb and put something and tie it up. That's the laparoscopic surgery, which is done. And there will be no single incision if the woman had not ruptured. If it is just a growing ectopic pregnancy and then causing discomfort, there's a way you can diagnose it using a scan, transvaginal scan, which is scan in the abdomen, and you see the pregnancy growing outside the womb. And once you determine that, you can actually put a telescope through the abdomen, through the lower umbilicus, and remove the ectopic pregnancy without the woman having another incision. But if it is ruptured, you may have to do a big incision to take care of it, to tie up the tube, to stop the bleeding. And then sometimes we can use the blood that the woman has ruptured and transfuse it back to the woman.
No, sorry, Dr. Morgan, we have been rounded off. So we'll take this to another time.
Okay,
I know it was getting more and more interesting, but that's how we conclude. That has been Cerhi Alpha. We looked at ectopic pregnancy, and the expert in the studios, Professor Friday Okonofor, has thrown sufficient light and enlightened us on the complications that could occur, on steps to take when there is incidence of ectopic pregnancy. We want to thank you, Prof, for coming to our studios.
Thank you very much for inviting me.
Thank you, Prof, and thank you, Dr. Morgan, for coming.
You're welcome.
See you.
Thank you for watching. Bye for now.